Okay, good morning, dear professors and colleagues. I'll try to be as easy as possible because the previous sessions were very, very difficult, I know. Our talk today is known, I'm telling about metabolic again and again. Okay, our case is SK, is a 10 years old female patient of non-consanguineous parents with totally normal developmental history and irrelevant past history with no family history also. Her condition started last November when the patient complained of abnormal gait that progressed slowly over 2 months duration with no sensory affection or urinary incontinence. 2 months later, our patient developed to start complaining of bilateral severe upper limb weakness with mild visual affection, and at this point, the patient was referred to us and was admitted at our unit. As usual, we started with Neuro Imaging. We did MRI brain and spine that showed abnormal focal high signal noted along the posterior aspect of brainstem, especially the tectum of midbrain and to little extent to the bones. This is also associated with similar faint abnormal high signals of optic nerve, particularly the optic chiasma and the prechiasmatic areas. And those findings, as mentioned in the MRI reports, are highly suggestive of NMO rather than MS. This is her MRI. I know that the quality is not very well, but you can see the lesions here and here, the optic chiasma and the brainstem affection. Also, MRI spine showed lung signal alteration down to C7. Apparent more posterior is also going with NMO. So at this point, with a previous history of a patient that was normal and suddenly presented with secondary inability to walk and upper limb weakness with visual affection, we go classically with neuroimaging as a case of neuromyelitis optica, and this was our first diagnosis. We did VEP to confirm our diagnosis that showed bilateral optic nerve dysfunction, and we diagnosed the patient as a case of NMO, despite aquaporin was negative, so the case was aquaporin negative neuromyelitis optica, and we decided to start our treatment. Based on this, we started the first line of treatment, which was pulse steroids and plasmapheresis. After finishing 3 sessions, the patient rapidly deteriorated with severe respiratory failure, upon which the patient was admitted on the PICU and was intubated. During her admission, patient received IVIG on 2 grams per kg with minimal improvement, so we started to think for another, our second line of treatment, which was rituximab at this point. Since then, we started to revise our diagnosis. Based on the previous session with Dr. Maha and Dr. Sarah, and with our experience with the previous patients, we suspected, as mentioned before, HLH. We started the first and almost going to the second line of treatment with no improvement, so we suspected it's HLH at this point. And after consultation with our hematology team, we started to investigate the patient as a case of HLH, waiting for rituximab. Then CSF showed no macrophages with negative serum HLH markers. All markers were done and were negative. At this point, we decided to go for whole exome sequencing as the last option to diagnose our patient. I just mentioned that at this point, the patient, we tried to do another MRI to compare the 2 findings, but the patient unfortunately was arrested at this point. So we have now a patient post-arrest with this previous history, intubated and admitted at the ICU, and this is why we are going, we're very rapid to diagnose the patient and start treatment as soon as possible. So the whole exome sequence was sent, but unfortunately it came with negative results. And this was so disappointing. However, in the next page in the whole exome sequencing, we found this note. The patient has mutation of biotinidase deficiency, which was very, very strange, as the presentation of the patient and the neuroimaging of the patient and the clinical history of the patient goes with an autoimmune process that mostly was neuromyelitis optica. However, the whole exome sequencing came to show us that this patient might be a case of biotinidase deficiency. Based on this, we already did the biotinidase level that was very low, 0.3, and normal was from 5.3 to 12.2. So our patient was diagnosed as a case of biotinidase deficiency. So what is biotinidase deficiency? Biotinidase deficiency, or biotin, is vitamin H, that is water-soluble vitamins that naturally found in many foods. It is an essential enzyme required for recycling biotin by lysine from biocytin. Type. What is the usual clinical spectrum of biotinidase deficiency that you used to experience in our clinics or hospital? Children with biotinidase deficiency usually presented at the age of 2 to 5 months, usually came with hypotonia, convulsions, ataxia, skin rash with, this is a very common presentation, alopecia, hearing loss. However, sometimes they may come with optic atrophy and breathing problems, and this is what happened with our patient at the age of 10 years, and sometimes developmental delay. Older children may be presented with involvement of both spinal cord and optic nerve, and this is our case. Our case was presented lately with spinal cord and optic nerve affection. However, spinal cord demyelination as a manifestation of biotinidase deficiency has been infrequently described in literature. However, despite this sentence, my dear Professor Dr. Huda Tomoum had already presented 2 SAPs around 2 to 3 years ago, presented with the same presentation almost, both at the age of 12 and 10.5 years, so they are SAPs, with the same presentation of spinal cord affection and affection, mainly motor affection. And those both were diagnosed later on as a case of biotinidase deficiency. So in our experience, it is not that rare. This is the first patient that with Professor Dr. Huda. This is his first presentation. You can see severe motor weakness. This is at his presentation. So at this point, biotinidase deficiency was a very, very far thinking about. So those are some papers published mentioning that profound biotinidase deficiency can be a late onset, not usually at the age of 2 to 5 months as we used to diagnose. Other paper, spinal cord demyelination associated with biotinidase deficiency in 3 Chinese patients. Also the same, profound biotinidase deficiency in a child with predominantly spinal cord disease. So biotinidase and spinal cord disease is not that rare. We have to think about. Lastly, this paper, biotinidase deficiency mimicking neuromyelitis optica in adulthood. And this paper, biotinidase deficiency mimicking neuromyelitis optica beginning at the age of 4 years. So now it is not that rare. So the question is, what is the relation between biotinidase deficiency and neuromyelitis optica? Why? Neuromyelitis optica, زي ما كلنا عارفين, is an inflammatory demyelinating disorder of the CNS, mainly associated with circulating antibodies, anti-aquaporin 4, that causes astrocyte necrosis in a complement-dependent manner. It is known that neurons and axons lose potassium to the extracellular space during action potential. It follows that they must eventually recover the potassium, which may be achieved with sodium-potassium ATPase pump. In biotinidase deficiency, that affect ATP supply. They have defective Krebs cycle, so potassium is not repumped efficiently enough. That leads to astrocyte swelling and astrocyte damage, and that may explain the relation between neuromyelitis optica and biotinidase deficiency. So we started the treatment for our patient based on our diagnosis. We started with biotin supplementation on dose of 10 milligram per day and titrated gradually according to the patient improvement up to 40 milligram per day. And this is our patient after treatment. I will revise with you that this patient was post-arrest at a point. This is our patient after starting biotin treatment. Now she can use her hand almost fine. My take-home message is biotinidase deficiency should be included in the differential diagnosis of children presenting with demyelinating spinal cord disease, particularly with involvement of the optic busway. احنا تعودنا دايما ان العيان اللي بيجي باوبتيك نيورايتس وسباينال كورد افكشن هو عيان نيورومايلايتس اوبتيكا الى ان يثبت عكس ذلك. اكشولي بعد الكيسز دي او بعد الكيس دي بالذات ابتدينا نقف نقول لا عادي ان البيشنت يجي باوبتيك نيورايتس وسباينال ماتر سباينال كورد افكشن ويطلع ميتابوليك. وذاتس واي البرزنتيشن دي اتحطت هنا لانه despite ان السيشن كلها بتتكلم عن autoimmune disease and this patient was presented initially with symptoms and signs suggestive of autoimmune disease, but we have to think again and again of metabolic disorders. Thank you.
Thank you very much for your excellent presentation. I totally agree with you because I have similar cases, so similar to your cases. Of vitamin D, since we don't have neonatal screening for vitamin D. If you diagnose very early, that you will get a very normal child. I have two cases presenting with transverse myelitis, or let's say myelopathy, by age of 6 years and 8 years. They are doing marvelously. They are now 22 or 24 years in the university, graduated. Everything is fine apart from the ear or using a hearing aid. And for the NMO, they don't regarding your case, as we have seen your case also, they don't respond to the first line and they don't respond to the plasma exchange, which are big criteria why they don't respond. And therefore you have to think, and this case also you have myelopathy or sort of myelitis NM. I totally agree with you. Thank you very much.
Thank you. Thank you.
For interesting case and presentation is excellent. I would emphasize also actually the point that you've raised, and I think we need to think always whenever we have any patients with unclassical presentation, even movement disorders, which I will touch base on tomorrow, inshallah, is to make sure that we are ruling out any treatable inborn error of metabolism. So you mentioned that the patient is suffering from ataxia. So even for movement disorders, we have to think for treatable ones in order not to miss. So even sometimes we do empiric, I know this is not like a thing that we follow. Nowadays, we have voice analysis, but sometimes you can have patients who cannot afford doing this, or you have difficulty reaching out for this. So it won't harm ever if you have such cases and start on high dose of biotin, and then you have therapeutic clue. So thank you so much.
Thank you. Thank you.
I have one more question. So Professor Lim, I have a question about Michael's presentation. Yeah, only one question. Okay, so actually we thought of HLH in that patient. Number one, would you think of it? This is my first question. My second question, do you have any explanation for the improvement after retox given to the patient?
Yeah. So I was going to make a comment about actually some of the mitochondrial, mimics of inflammation and demyelination, and all of them are actually responsive to steroids. So you get fooled, occasionally with regards to that. So specifically to the retups, I mean, there's no, I can't think of a logical, sort of explanation why might that be the case, unless, of course, that, there is secondary inflammation and it just so happened to, respond to retux, or it was going to just get better transiently over time before the deterioration again. So the answer is I don't really know. But for the mitochondrials, I've been caught out more often than not that, you get a 10-day improvement. So maybe that lesion was inflamed, you got a little bit of improvement, and then it got worse again.
Okay, and would you think of HLH?
Oh, would I think of HLH? Of course, now I would. I hope you didn't. I hope you hadn't secretly emailed me, and I hadn't thought about it, and then you kept that email as a proof that I hadn't thought of that. No, yes. I think particularly now when there's so much, sort of coverage and it's the next thing, I think we just got to be careful as well that we don't over call HLH. So I'm run one of the meetings in London, and virtually everything, we can't make a diagnosis of everyone saying, oh, could this be HLH? I think you've got to have some criteria, as you said, the key being an active brain lesion or some regression of skills rather than just a few blobs here and there in a well child.
And no one would believe me.
Thanks.
Okay, any other question? So we come to the last presentation in our session, again with Professor Lim. It's my honor to present him in this very attractive presentation with very attractive title, MS